Okay, so we're going to be talking about the last subcategory in distributive shock, and that one is neurogenic shock. So basically, we're talking about the central nervous system, so basically the brain all the way down the spinal cord. So what happens in a neurogenic shock? So we're looking at a sudden loss of sympathetic tone in the nervous system. So remember back in the original shock loss course, we talked about the autonomic nervous system, and basically this is the fight or flight. This is the one that's you're going to rev you up and get you going. It no longer can do that. It's not giving out that tone. So whether you've had damage either to the spinal cord to send the signal out, or the brain can't receive the signal or send the signal back and forth. One of the most common causes of shock is due to the spinal cord. So we're talking about whether it's an actual injury to the spinal cord, you might get some swelling, but a lot of times it's actually a true damage to that spinal cord where it's actually cut in half. Basically, it just disrupts the communication between basically the brain and the rest of the nervous system. So the sympathetic tone cannot be enforced, like they're not releasing epinephrine or norepi. So again, like I just said, or epinephrine and norepinephrine isn't being released, so therefore that the sympathetic tone cannot happen. So therefore we can't just rev up. So there is the difference here with the neurogenic shock when we're doing this, because what will happen is that there's some special signs and symptoms that come with it compared to the rest of the signs and symptoms. Everybody else usually is pale, sweaty, right? They become tachycardic and they're compensated. But in the neurogenic shock, they're usually warm, a little red, and dry. And that's because of that vasodilation, right? They've lost control of being able to dilate at the macro level. Next is they get bradycardic because they don't have that drive. The drive isn't being released to tell them to increase the heart rate. Again, they end up with a low blood pressure because they can't constrict, because that container is so big it can't constrict it anymore. It's not being told to like tighten it up. So again, like we talked about all the time, there's supportive care that we do. If you're just a level entry into EMS and your scope isn't that big, just think of that supportive care, give them some oxygen if they need it, get them to a hospital. A lot of times they'll have signs or symptoms where they may not be able to move a type of body part or something like that, and they might be struggling, those things. In the supportive care, if it's high enough up, you might actually person be unconscious, they're in reversible shock, and you're going to have to take over those blocks for them. You're going to have to ventilate and make sure that a lot of times if you just get in there and ventilate the patient really well, you'll find that that alone can actually help the patient. But the big thing too is we're also looking at vasoconstrictors as well. So don't be afraid to phone ALS for, ask a friend to meet you halfway to get that going. And again, like I said, early transport. Don't spend a lot of time on scene. Get rolling towards the hospital, and if they're super sick, let the hospital know that you're coming. So when we jump over to the board here and look at what's going on, if you think about it, the instructions are going back and forth, right? To maintain vascular space. It reads some information from the body, sensor over here, it goes back up, brain gets it, tells it to do something, and like, oh, look at that, we got enough blood, we're maintaining. Okay, oh my God. Oh, it looks like we don't have a lot of blood. So what's going to happen is that it's just going to send a signal back, it's going to come back, and then the next one it's going to do is it's going to tell it to constrict itself. The only problem though is in neurogenic shock, what's happening is somewhere in here there's some damage, right? The signal is just not going either way, right? The signal's broken in the middle somewhere, and basically what happens is the vascular system goes blah, just opens up, fully dilates, and there's no control, there's no signaling going back and forth. So that's like your epi norepi. Also because that's happening as well, because that's what increases your heart rate, right? Increases your your heart rate to go up, increases your respiratory rate, and it actually controls your container. Those three things, the sympathetic response, makes you breathe faster, makes your heart beat faster to help maintain that. So what happens is, if you think about it, when we talked about compensated and decompensated shock, this one's a little scarier, because we've lost the ability to compensate because the information isn't going back and forth. So as a practitioner, we have to be aware of that neurogenic shock that we're going to might have to step in and you know build in some blocks, right, to help maintain this patient, block in some of the stuff. And that's, like I said, the vasoconstrictors, right? You get vasoconstrictor, you inject it, and then hopefully we can maintain it and get some type of adequate blood flow. Anyways, that is the last one of all our shocks. They're not super long, but they're a little finicky. Each one of them has something very unique about them. Make sure you understand it. Make sure you understand them well enough to actually understand that you can recognize that shock is starting early on, because like we talked before, is you're better off to get in there when there's some type of behavior change at the beginning, because the treatment effort is way easier at the beginning than versus, like, say, decompensated shock, because you're dealing with multiple organs that aren't working and there's a lot of failing going on. And out of the shock blocks, all those shock blocks now are struggling to maintain perfusion. Anyways, thank you for this one, and we'll be having another one coming up in the series, probably more on individual medical emergencies and other types of trauma. Anyways, I'm Jason Jolson. It was good going through this course with you, and we'll see you in the next one.